Hello everyone, now let us discuss about part 3 of anti-anginal drugs. And in the current session, we will be studying about calcium channel blockers, especially phenylalkylamines and benzothiazepines. Coming to angina, angina is not a disease, but it is a pain syndrome. It is a feeling of pain, squeezing or pressure in the chest. An induction of an adverse oxygen supply demand situation in a particular portion of myocardium often leads to angina. The treatment and management options of angina pectoris are medication, lifestyle changes, and surgical procedures. Now coming to calcium channels. There are basically three types of calcium channels. They are voltage sensitive, receptor operated or mediated, and leak channels. The voltage sensitive channels, they are activated when membrane potential drops to minus 40 millivolts. There are basically three types of voltage sensitive calcium channels. They are L-type, T-type and N-type. Now coming to receptor operated or mediated calcium channels, they are activated by adrenaline and other agonists. Coming to leak channels, the mechanical stress promotes the inward movement of calcium through the leak channels. Now coming to voltage sensitive calcium channels. Voltage sensitive calcium channels are majorly present in the heart. So let us discuss briefly about the different types of voltage sensitive calcium channels. As we have discussed earlier, they are divided into three types: L-type, T-type and N-type. Here, L-type is nothing but long lasting current and T-type is nothing but transient current and N is nothing but neuronal. Coming to the conductance of L-type is 25 PS and T-type is 8 PS and N-type is 12 to 20 PS. PS is nothing but peta-segments, unit of conductance. The activation threshold of L-type calcium channels is high, whereas T-type is low and N-type is medium. And similarly, the inactivation rate of L-type is slow, T-type is fast and N-type is medium. Coming to the location and function, the L-type calcium channels, they mainly involve excitation, which leads to contraction, coupling in cardiac and smooth muscles. In case of SA node and AV node, they increase the conductivity. And in case of endocrine cells, they lead to hormone release, and in case of neurons, they lead to transmitter release. These are the functions of L-type calcium channels. And the specific blockers of L-type calcium channels are Nifedipine, Diltiazem and Verapamil. Coming to T-type, they are located in SA node and they are mainly involved in the pacemaker activity. The T current and the repetitive spikes in the thalamic and other neurons. And in case of endocrine cells, they lead to hormone release, and in certain arteries, they lead to constriction, the T-type calcium channels. Coming to the specific blockers of T-type calcium channels are mebifradil, flunarizine and ethosuximide. And coming to the N-type, they are present only in neurons in CNS, in sympathetic and myenteric plexus. They mainly lead to transmitter release. The specific blocker is chronotropic. In the current session, we will be focusing only on the L type of calcium channels. So coming to calcium channel blockers, only L-type calcium channels are blocked by calcium channel blockers. All calcium channel blockers, they bind primarily to open or inactivated states of calcium channels, and each specific subtype. For example, the calcium channel blockers are categorized into three subtypes: phenylalkylamine, benzothiazepines and dihydropyridine. Each of them has a specific binding site on the respective calcium channels. And the calcium channel blockers have been grouped into three chemical classes which have distinctive pharmacodynamic profiles. The example of phenylalkylamines is verapamil, The verapamil drug is hydrophilic, it is less potent, and it has cardiodepressant actions. Coming to the next category, they are benzothiazepines. Example is diltiazem. It is hydrophilic, less potent, and it has both cardiodepressant and vasodilation action. Coming to dihydropyridines. Example is nifedipine. It is lipophilic and it is a more potent vasodilator. In the current session, we will be discussing about phenylalkylamines and benzothiazepines, and in the next session, let us discuss about dihydropyridines. Now coming to the classification of calcium channel blockers. They are broadly categorized into three types based on the chemical group. They are phenylalkylamine, benzothiazepines and dihydropyridines. So example of phenylalkylamine is verapamil, and example of benzothiazepines is diltiazem, and example of dihydropyridines are nifedipine, amlodipine, lacidipine, benidipine, nimodipine, felodipine, etc. So dihydropyridine as such is a big topic. So let us discuss in detail about dihydropyridines in the next session. Here we will be focusing only on verapamil and diltiazem. Coming to the pharmacological actions. The cardiac effects of calcium channel blockers are majorly three. They are decrease in contractility, heart rate and conduction velocity. The decrease in contractility is nothing but negative inotropy, and decrease in heart rate is nothing but negative chronotropy, and decrease in conduction velocity is nothing but negative dromotrophy. So these three are the major cardiac effects of calcium channel blockers. The vascular effects are smooth muscle relaxation and vasodilation. Coming to smooth muscle relaxation or vasodilation. The smooth muscle depolarize primarily by inward calcium movement through L-type calcium channels. The calcium ion triggers the release of more calcium ions from the intracellular source such as sarcoplasmic reticulum. And this leads to phosphorylation of myosin light chain, which activates the actin and myosin coupling, and thus that leads to contraction of vascular smooth muscle. So this is the basic mechanism. Here the calcium channel blockers, they cause relaxation by decreasing the intracellular calcium availability. Because the calcium channels, they block the calcium entry, intracellular calcium availability is reduced and that leads to relaxation. Systemic vasodilation reduces the arterial pressure, which reduces ventricular afterload. That is nothing but the wall stress, decreasing the oxygen demand. They cause relaxation by decreasing the intracellular calcium availability, and due to systemic vasodilation, they decrease the oxygen demand. These two are the major effects of calcium channel blockers: relaxation and decreasing the oxygen demand. The calcium channel blockers, they markedly relax the arterioles, but they have mild effect on veins. And additionally, extravascular smooth muscles like bronchial, biliary, intestinal, vesical and uterine are also relaxed by calcium channel blockers. Dihydropyridines, they have the most marked smooth muscle relaxant and vasodilatory action. When it comes to smooth muscle relaxation and vasodilation, the dihydropyridines have the most marked smooth muscle relaxant and vasodilatory action. Verapamil is somewhat weaker, followed by diltiazem. So the order of vasodilation and smooth muscle relaxation is as follows. The first one is dihydropyridines, followed by verapamil and followed by diltiazem. And additionally, nitrendipine and few dihydropyridines, they have been shown to release the nitric oxide from endothelium and inhibit the cyclic AMP phosphodiesterase, resulting in the raised smooth muscle cyclic AMP, further enhancing the relaxation. And the released nitric oxide may also exhibit anti-atherosclerotic action. Coming to the cardiac effects. As we have discussed, there are majorly three cardiac effects of calcium channel blockers: negative inotropic effect, negative chronotropic effect, and negative dromotropic effect in general. So, coming to the mechanism of negative inotropic effect, that is nothing but decrease in contractility. In atria and ventricular fibers, calcium moves in during the plateau phase of action potential. This is an important point. In atrial and ventricular fibers, the calcium moves in during the plateau phase of action potential. This leads to release of more calcium from the sarcoplasmic reticulum, and this results in contraction by binding to troponin, allowing the actin and myosin interaction. Calcium channel blockers, as they block the movement of calcium, they decrease the myocardial contractility, and additionally they lead to reduction in the myocardial oxygen supply. Coming to the negative chronotropic effect. By blocking the calcium channel during the plateau phase of action potential of the heart, calcium channel blockers, they lead to slowing down of the conduction of electrical activity within the heart, and this results in reduced heart rate. That is nothing but negative chronotropic effect. Coming to negative dromotropic effect. The phase 0 depolarization in the SA node and AV node are calcium ion mediated. The phase 0 depolarization in SA node and AV node are calcium ion mediated, and because they block calcium channels, they block the calcium entry, automaticity and the conductivity, which depend on the rate of recovery of calcium channel, is altered. So the calcium channel blockers, they slows the conduction and exert a negative dromotropic effect, because they also delay the calcium channel recovery. First thing is they block the entry of calcium channel, and secondly they delay the recovery of calcium channel. By these two actions, the calcium channel blockers, they slow the conduction velocity of AV node, leading to negative dromotropic effect. So the L-type calcium channels, they activate and inactivate at slow rate. The L-type calcium channels, they activate and inactivate at slow rate, and the calcium depolarized cells, especially in case of SA and AV node, have less steep phase 0 and longer refractory period. And the recovery process by membrane depolarization is delayed by verapamil and diltiazem. The recovery process of calcium channel is delayed by verapamil and diltiazem, leading to the depression of pacemaker activity and conduction. And additionally, the blockade by verapamil is enhanced at higher rates of stimulation, hence it slows the sinus rate and AV conduction. These two actions are not achieved by dihydropyridines. The recovery process, the delay in the recovery process is mainly achieved by verapamil and diltiazem. Here you can see this is the activated channel and this is an inactivated channel, and this is a resting channel. So usually channel takes some time in order to get converted from inactivated to resting. So once it enters the resting state, it can be easily activated by depolarization. But this process, the recovery process, which is time dependent, it is delayed by verapamil and diltiazem, and this leads to depression of pacemaker activity and conduction. Coming to the drug, that is verapamil. It dilates the arterioles and has some alpha adrenergic blocking activity. Thereby, it reduces the total peripheral resistance and BP is modestly reduced. Verapamil does not affect the blood pressure. Usually, it reduces the total peripheral resistance. And the pronounced cardiodepressant effects are not seen as prominently in vivo by reflex effects of peripheral vasodilation. And the important point is the verapamil has the most marked negative inotropic action. Among the calcium channel blockers, verapamil has the most marked negative inotropic action and it is contraindicated in heart failure. And it usually lowers the heart rate, AV conduction is lowered, but the cardiac output is maintained by reflex sympathetic stimulation. And the reduction in aortic impedance, which is nothing but resistance. Additionally, ventricular contractility is markedly impaired in congestive heart failure patients, hence it is contraindicated. And coronary flow is also increased by verapamil. These are some of the pharmacological actions of verapamil. It lowers the heart rate, it improves the coronary flow, it slows the AV conduction, but the cardiac output is maintained by reflex sympathetic stimulation. And one more important point is it has most marked negative inotropic action and hence it is contraindicated in heart failure. Coming to the uses, it is majorly used for vasospastic angina, hypertension, paroxysmal supraventricular tachycardia and control of ventricular rate in atrial fibrillation and in prevention of migraines. The pharmacokinetics are it is given orally and the estimated mean elimination T-half is 2.8 to 7 hours with single dose. Repetitive dosing due to accumulation, it increases the elimination half-life to 4.5 to 12 hours. Usually the bioavailability is high for verapamil. Coming to side effects, constipation is the most common side effect of verapamil because of its action on GI tract. Additionally, bradycardia and nausea are also common, whereas headache, flushing and ankle edema are less common. Even asystole is also less common. Coming to the contraindications, verapamil is contraindicated in severe hypotension, congestive heart failure, left ventricular dysfunction, and also in patients who have sick sinus syndrome, and in case of second and third degree AV block, and in case of cardiogenic shock. These are the conditions where verapamil is contraindicated. Coming to the drug interactions, verapamil when given along with beta blockers or other cardiac depressants, it leads to additive sinus depression, conduction defects, or even asystole. Hence, it is contraindicated in sick sinus syndrome and patients with congestive heart failure. And one more interaction is digitalis toxicity may develop whenever it is co-administered with verapamil. Coming to the marketed formulations, the formulations which are available are calaptin 40 and 80 mg tablets, 120 and 240 mg sustained release tablets and 5 mg per 2 ml injections. The next one is Vasopten. It is available as 40, 80 and 120 mg tablets. Coming to the next drug, it is Diltiazem. As we all know, it blocks the L-type calcium channels, both cardiac and vascular. It is somewhat less potent vasodilator than Nifedipine and Verapamil, and it has a modest direct negative inotropic action. And the direct depression of SA and AV nodal conduction are equivalent to Verapamil. Additionally, a non-specific antiadrenergic action has also been demonstrated by Diltiazem. One more important point is the clinical doses produce consistent fall in blood pressure with little change or decrease in the heart rate. And the large dose or IV injection, it decreases the total peripheral resistance, which may elicit reflex cardiac effects, and it dilates the coronaries. These are some of the pharmacological actions of diltiazem. Coming to the uses of diltiazem, it is used in vasospastic and classic angina, hypertension, and to control the ventricular rate. Coming to the pharmacokinetics, it is given orally. The plasma elimination half-life is 3 to 4.5 hours, and lower doses should be given to patients on beta blockers. Coming to the side effects, they are similar to verapamil, like constipation, bradycardia, AV conduction block, and hypotension. Coming to the contraindications, diltiazem is contraindicated in hypotension, sickle sinus syndrome, second and third degree AV block, acute myocardial infarction, pulmonary congestion, and in case of lactation also. Coming to the markedly available formulations, they are Diltiazem 30 and 60 mg tablets and 90 mg sustained release tablets, and also 25 mg per ml injection. And Anginal, it is available in 30, 60, 90, 120, 180 mg tablets. And next, Diltiazem, it is available in 30 and 60 mg tablets and also as 90 and 120 mg sustained release tablets. Thank you for watching. Please subscribe for further videos on pharmacology and other related pharmaceutical sciences.